All right. Thank you everyone for being here despite the cold. We're glad that there hasn't been precipitation with it, but hopefully our lives aren't too disrupted with school closures and things like that. But thank you for making time to be here for today's Department of Medicine Grand Rounds. We are very excited to have one of our very own within our Division of General Medicine, Dr. Pam Vohra-Khullar, who is an assistant professor in the Department of Medicine at Emory. She joined faculty in 2013 as a general internist. She's the site director for the internal medicine resident clinic at the Emory Clinic, as well as director for the required outpatient experience for our preclinical medical students, and a practicing faculty member within the Emory Clinic. Her educational interests include artificial intelligence implementation in primary care, ambulatory teaching, and patient-doctor communication. Her clinical interests include preventative screenings, women's health, and comprehensive chronic disease management. Dr. Vohra completed her undergraduate studies at Harvard University. She earned her medical school degree at the University of Chicago's Pritzker School of Medicine and completed her internal medicine residency at Beth Israel Deaconess Medical Center's primary care track. And we are very excited to have her here today, getting us all up to speed on current cancer screening recommendations. Thank you so much.
Thank you, Annie, for inviting me and introducing me. So our talk is called Detect to Protect Current Cancer Screening Recommendations. I have no financial disclosures, and so we'll leap right in. We have three learning objectives today. First of all, hopefully you'll leave this talk and understand the current guidelines for five of the major cancers. You'll be able to evaluate different screening modalities for those cancers and think about your individual patient risk factors and other characteristics to help decide what recommendations you might make for an individual patient. So this is a typical patient in primary care. It's a 61-year-old female who's presenting for her annual physical. She's interested in cancer screening. Her last colonoscopy was in 2020 and showed an adenomatous polyp. Her last mammogram was in January 2024. She had a pap smear in July that was normal with negative HPV testing, and she continues to smoke 10 cigarettes per day. She's been trying to quit, but she's never been screened for lung cancer. So what cancer should you screen her for? As you're trying to go through each one and think about when you would order the next one, a few more details pop up. So first of all, you notice that her father had colon cancer at age 60. And so she asked, well, what about that family history? Should I be screened sooner? The next thing that you notice is when you look through her mammogram report, it notes that she has dense breast tissue. And so she asked, what about the dense breast tissue? Should I get an ultrasound or an MRI? And then when you look at her pap smear, you think she's 61. And she says, Doc, do I need any more pap smears or am I done since I'm 61? And the last thing you know that lung cancer screening is something that we're not doing all that much, but that you should. And so does she qualify for lung cancer screening? So hopefully at the end of this, you'll be answered all of these questions and a few more by the end of the talk. So when we think about the cancer screening in general, an estimated 609,820 Americans died of cancer in 2023. And so when we look at new cancer cases here in the first pie chart, you can see that breast cancer is our number one. Number two is prostate in green. Lung cancer is in red at 12%, and then colon cancer is 8%. In terms of cancer deaths on the right, you can see that lung cancer is our number one at 21%. At about half of that, we have colon cancer in purple, pancreatic cancer in yellow, and breast cancer in blue. We're going to spend most of our time talking about these four top cancers, and then we'll also add cervical cancer into this group. When we think about why am I not talking about screening for pancreatic cancer, I think it begs the question of what makes a good screening test. And so these are old criteria that we probably learned during our training, but a test should be reasonably priced and non-invasive. This is important for any screening test. It should try to identify a disease that's clinically significant, that has a latent stage, and that has an acceptable treatment. And then the test should be highly sensitive and specific. So if you think about pancreatic cancer and you ask yourself, do we have a screening test for that cancer that would pass most of these bars? We don't really. And so we'll talk about the cancers that we do screen for and those screening tests and why they might be better at meeting some of these criteria. Then the next question is who helps us evaluate what cancers we should screen for and what are good screening tests? There are a lot of different societies that help make recommendations, and there's a lot of primary literature out there. Cancer screening is one of those areas that for many of us, including in primary care, patients have strong opinions about it, and all of us have seen patients who've been diagnosed with cancer when they didn't meet guideline-based screening. And so today I'm going to mostly be talking about the guidelines from the United States Preventative Services Task Force, or the USPSTF. This is an independent volunteer panel of national experts in prevention and primary care, and they make evidence-based recommendations about clinical preventive services. Most of these are services that can be delivered or referred from a primary care setting. Their mandate is go where the evidence leads. So they make recommendations based on the strength of evidence and the balance of benefits and harms. And they try to identify critical gaps in the scientific evidence. They give charts with recommendations that are graded like this: A, B, C, D, and I. Recommendations that are A or B are things that we should offer or provide. Either there's a high certainty that the benefit is substantial, or there's a moderate benefit or moderate certainty. Those are the B recommendations. We'll talk about some recommendations today that are given a C grade. So those are probably selectively offer those screening tests based on patient preferences and professional judgment. The benefit here is usually small. Grade D is for recommendations against doing this screening test. So we should discourage these services because the harms outweigh the benefits. And then I statements is where the evidence is insufficient. It doesn't mean that you shouldn't order the test or you shouldn't screen here, but we're not really sure about the net benefit and because of lack of evidence. So tests that are given an A or B rating are covered under the Affordable Care Act with usually very little cost sharing for a patient. So those services are important. Many other specialty organizations will make recommendations about cancer screening, as I mentioned. They are able to use expert opinion, and the USPSTF does not publish recommendations that are based on expert opinion, only based on evidence. And that's probably the main source of difference between the two. Between the USPSTF and others. So they do have an app to help you remember all their recommendations. It's called Prevention Task Force, and it's from the Agency of Healthcare Research and Quality. It goes through, you put in your patient demographics on the first screen, and then it'll tell you all the recommendations. This includes cancer screening as well as infection screening and other types of screening tests. Vaccines will all come up in this one app. So now we're going to jump in and talk about the 5 main cancers today. So we'll start with colon cancer. So screening for colon cancer is, very important and part of our routine practice. It's the second leading cause of cancer death in the U.S., like I showed in that chart, and only about 1/3 of eligible adults and 1/3 of adults have never been screened. So these are, a big group that we should be able to access and promote screening. Many of you remember this that came out a few years ago in 2021, where 45 is the new 50. So we moved colon cancer screening from 50 back to 45. And so this recommendation was updated, like I said, in 2021, and it's a grade B recommendation to screen between ages of 45 and 49. To screen for 50 and older is still a grade A recommendation. So this is a summary of the recommendation. So start at age 45. You can do a stool-based test or a direct visualization test, and that's for ages 45 to 75. And that the screening intervals and the test really characteristics will vary by test. And then do not routinely screen for those who are 76 to 85. Among that age group, the patients who benefit most are patients who've never been previously screened. So oftentimes we'll have patients who didn't have access to care who come to our practice, or patients who may have come from other countries where colon cancer screening wasn't the norm. Those patients might be the ones who benefit the most. And then really the recommendation is to stop after age 85. So most of our patients, there should be no more screening after that age. So why did we move the age back from 50 to 45? So this is the next two slides are both charts from the um, recommendation from 2021, and it shows what the benefit is for cases averted if you started screening at age 45 versus 50. So the two tests that I've highlighted with the blue arrows here are the FIT test, which is fecal immunochemical testing every year, and then this one here, which is colonoscopy every 10 years. And for both of those tests in yellow circles, I've shown the number of additional cancer cases that are averted by starting to screen at 45, and it's 3 cancer cases for both of those. So that's a small benefit. This one looks at screening at age 45 and how many deaths are averted. So again, I've highlighted the same two tests with the blue arrows, the FIT test and the colonoscopy, and the additional deaths that are saved per 1,000 individuals screened is 1 additional patient. So these are small benefits, which I think is why it got a B recommendation and not an A recommendation. One question that comes up a lot in clinical practice is how should we screen for colorectal cancer for Black Americans? What we know is that Black Americans have a higher incidence of colorectal cancer and a higher mortality. In 2020, many of you remember when Chadwick Boseman died. I think it really entered the national consciousness of, are we doing the right job, are we aggressive enough in screening Black Americans? And in 2021, the USPSTF updated their colon cancer screenings. That's when they went back from 50 to 45. But they said there was no specific recommendation for screening for Black Americans. And more specifically, they said that it was inequities to the access, utilization, and quality of screening and treatment as the primary driver for the healthcare disparity rather than genetic differences. So I usually, try to emphasize that we need to have testing and we need to have some sort of screening discussed with patients, even if they're not there for their annual physical. We need to be checking in to make sure that we're referring patients for screening tests. So next question is how? How should we screen patients for colorectal cancer? And our colonoscopy is the gold standard test. Most of us know that. It's the only screening test that detects cancer and prevents cancer. It's touted as such because by snipping out precancerous polyps, we think that we can delay the onset of cancer by several years. Although the colonoscopy is probably our best test, the recommendations list 7 different testing methods that you can do for colon cancer screening. This chart is very detailed, which goes over the evidence of efficacy and screening intervals for each of them. But I think the most important takeaway from the slide is one, there are stool-based tests that you can choose between, and that's 3 of them. And then secondly, there are direct visualization tests, which are here on the bottom, and there are 4 of those. So you have 2 types of tests based on patient preference. There are 7 methods total. So it's not, does a patient want a colonoscopy? It's, does your patient want colorectal cancer screening? The USPSTF says that there's no data that any of the above strategies provides a greater net benefit. There are specialty societies that will tier the testing. And so, we talked about colonoscopy being our gold standard. And then the fecal immunical testing, this FIT test is probably also in our top tier for testing. And some of the other tests fall under lower tiers. So those are probably the 2 that are favored in primary care. But I remind this to trainees and I remind this to patients almost every day. The best test is the one that the patient will get done in the next year. And so I often ask patients, which test do you think is most likely that you'll be able to do in the next year? Because it's important to me that you get screened. All right, next question is who has to have a colonoscopy instead of a non-invasive test? So you have a patient who's all sold on doing one of the stool-based tests, but then you decide, you know what, based on your history, I don't think this is the right test for you. So those are anyone who's high risk. And when we think about high risk in this situation, we're thinking about patients with a prior history of colon cancer adenoma, patients who have a personal history of IBD, if you have a family history of a hereditary colon cancer syndrome, like Lynch syndrome or familial adenomatous polyposis, or if you have a family history of colon cancer. So these are patients who probably should go for a colonoscopy. The family history of colon cancer can be a very big category. And so there are some recommendations that probably have weak evidence, but These are probably the best recommendations I have found. So the table is published from a 2018 American Family Physician article, but the data from it is really from a multi-society task force on colon cancer. Their recommendation is to look at how many first-degree relatives have had colon cancer or an advanced adenoma and look at what age they were diagnosed. So if you have a patient like our patient in the example case who was had one family member, first degree, who had colon cancer diagnosed at age 60, that patient should probably start screening at age 45 and then repeat it every 10 years. If you have a patient who has a first degree relative who was diagnosed with cancer at under age 60, then you should probably start at 40 or 10 years younger than the first age of diagnosis and screen them every 5 years. And then if there's two first degree relatives, you'll do something similar. Like I said, these are weak recommendations based on low quality evidence, but I think it gives us some guidance to help with when patients have family history. When do you need to order the next colonoscopy? This is again from the Multi-Society Task Force on Colon Cancer. I'm not going to go over the details, but as a primary care doctor, this was always a very difficult area for us, is you look at the colonoscopy report and then try and give some guidance to the patient about when their next colonoscopy should be. And so these types of charts have made it much more clear that based on the pathology and the size of the polyp, we can make clear recommendations to patients about when they should come back for the next one. All right, so I'm going to summarize take-home points for colon cancer. Start offering screening at age 45, and there are many options. So you want to prioritize patient preference unless they're high risk. All right, so we're going to move on and now talk about lung cancer screening. So lung cancer is the leading cause of cancer-related death in U.S. adults. And in this case, only about 15% of eligible candidates have been screened. So for colon cancer, it was 67% have been screened, and here only about 15% have been screened. The recommendation is annual screening with a low-dose CAT scan for ages 50 through 80. That recommendation was made in 2021. So you have to have a 20-pack year smoking history at least. You have to currently smoke or have smoked within the past 15 years. And we abbreviate this as A for annual, 50 to 80, 20-pack year history with 15 years smoked within the past 15 years. So the recommendations were based on two large study trials. The Nelson trial came out in 2020. Those screened those ages 50 to 74 who'd smoked 15-pack years. They compared in their two groups those who were screened with those who did not have any screening. The population was a European population and predominantly male. The National Lung Cancer Screening Trial was done in 2011. That was a US-based trial, which looked at 30 centers in the US, also predominantly male. That you had to be 55 to 74 for that study and smoke at least 30-pack years. And for this trial, they compared low-dose CT scan versus a chest X-ray, so slightly different comparisons. I'm going to show you the graphs from the Nelson trial from 2020. So the top graph shows lung cancer incidence. The bottom one shows mortality. Blue is our screening group and red is our control group. And you can see that those who had a lung cancer CT scan in the screening group had higher lung cancer incidence and lower lung cancer mortality. Overall, there was a 2.1% referral rate for suspicious nodules. So those are patients who had a CAT scan, not just the regular nodule, but a nodule that needed to be referred for surgery. The incidence of lung cancer was overall low, so 5.58 cases over 1,000 person years compared to 4.91 in control, so less than one additional case that was diagnosed. And the lung cancer mortality was 2.5 deaths versus 3.3, so less than one person whose death was averted from lung cancer. So this might not sound all that impressive, but then if you look at the stage at the time of diagnosis, you can see that in the screening group, more lung cancers were diagnosed in early stage, so in stage 1, 40% versus 14% in the control group. And then in the control group, more of the cases were diagnosed in stage 4, which was 46% of the cancer cases. So you could say that the incidence of lung cancer was for earlier stage lung cancer, which probably helped contribute to the lower mortality. So what are the screening risks for lung cancer? One of them is incidental findings. Whenever we get CAT scans, we often find things that we have to follow for several years. The most common incidental findings, though, are emphysema and coronary calcifications, which are things that we often are not surprised to see in our patients who have a smoking history. There's a high false positive rate, so 96% is an estimate of how many nodules are not going to be cancerous. So there's a lot. So this high false positive rate, as you could guess, leads to a lot of patient distress. Patients need to be screened annually, so you need serial screening. And you might be following a nodule for years, watching it grow slowly over 5 years, 10 years, before you decide that it's large enough that it needs to have biopsy to look for cancer. The other risk is radiation. So patients sometimes ask about this. We're doing a low dose CAT scan, which the radiation is about 1.4 compared to what a standard chest CT is 7. So it's 1/5 the radiation. A chest x-ray comparatively only has 0.1, and mammograms are 0.4. And so they definitely have more radiation than a chest x-ray or a mammogram, but not as much as a standard chest CT. Some studies have looked to see what does that cumulative radiation dosing do to a patient. It's estimated that for every 108 lung cancers discovered by screening, that one major cancer would be induced by radiation. So there's kind of a risk benefit there when you look at a population that you're screening. Lung cancer screening really relies on shared decision making. We talked about the high false positives and some of that patient distress. There are decision aids that you can use, and I have one with a website down below. The decision-making process is very important because patients have to adhere to annual lung cancer screening. You don't want to see a nodule 1 year and then not follow it for several years. And then they have to be able and or willing to undergo the diagnosis and to undergo the treatment. So I always talk to patients about whether or not we found something, if they would be willing to go for surgery to help diagnose it and then for treatment. The next question is when to stop screening. Well, really, we stop screening when patients are unable or unwilling to have curative lung surgery. And if their life expectancy seems like it would be limited, so really less than 10 years. This is an example of that screening tool that I was talking about, the lung cancer screening risk calculator. So on the left, you can type in the demographics about your patient, and then it'll, based on those results, it'll tell you here whether or not this is in an area where a patient strongly needs to be encouraged to undergo screening, where the patient doesn't qualify and you should discourage screening here in orange, or if they're in this middle gray bar, where it's really based on patient preference. They have some charts which you can go through with patients about the benefits of being screened or not screened. They have an example script, and for those of us who need to chart this for Medicare patients, they have a CMS required note to put in to show that we talked about shared decision making with the patient for compliance purposes. So most of the screening tests that I'm discussing today are all covered by CMS. This is one big caveat. CMS looked at all the different studies that have been done for lung cancer screening, and really the oldest that they looked at was at age 76. And so the two trials that I showed you, both of those only screened up until age 74. And so CMS feels that there's no relevant published human clinical study literature regarding low-dose CT scan in persons aged 77 to 80. The USPSTF says that, that they use modeling data for those age years in order to make their recommendations. So for CMS, we can only screen patients between the ages of 50 and 77 instead of 50 to 80. And like I said, CMS really requires documentation in your note that you did go through a shared decision-making process with the patient. All right, so these are the take-home points about screening for lung cancer. Low dose CT is really an underutilized strategy right now. We recommend offer screening at age 50, and that shared decision making is very important. All right, we're going to move on and talk more about prostate cancer now. So, prostate cancer is the leading cause of cancer for men in the US. The things that you probably learned in medical school still hold true. So, prostate cancer often grows so slowly that most males will die of other causes before the disease becomes clinically advanced. So, the general teaching is that many men will die with prostate cancer, not of prostate cancer. And that still overall is true. Um, it's kind of with that basis that these prostate cancer screening recommendations were made. So 2018 was the latest update by the USPSTF. And before this, the prior recommendation in 2013 had said do not screen. And so this was a little bit more of a nuanced recommendation. And it said consider screening at age 55. And that there should be shared decision making with the patient. So they gave it a level C, that the level of benefit is relatively low, but it could apply for certain specific patients. If you are going to do screening, they recommended screening with a PSA test for ages 55 to 69. And they recommended not to screen for those who are over the age of 70. So in comparison, I'll put up what the American Urologic Association says in 2023. They're the major specialty group that comments about prostate cancer. They recommended to consider starting at 45 to 50. So they want to start 5 to 10 years earlier than what the USPSTF recommends. They also recommend shared decision making. So that's an important part of their recommendation. And they said that you should screen with the PSA test also from ages 50 to 69, and that the PSA test can be done every 2 to 4 years based on what your initial PSA result was. So they're a little bit more specific about the PSA screening interval. They also recommend to not screen for those age over 70. So I put them both up here to show that there are definitely similarities. The shared decision making is a similarity, and the not screening over the age of 70 is a similarity. But the use of the PSA test is a similarity. Digital rectal exam is not recommended by either due to lack of evidence of benefit through that method of screening. What are the risks of prostate cancer? These I think we're kind of well versed in. There's overdiagnosis, cancers that probably are not clinically relevant for patients. There's the false positive risk. There's the risk of the prostate biopsy procedure itself, and there's also the patient anxiety. So this is an infographic that's part of the 2018 USPSTF recommendation. They had this in their patient handout to discuss with patients. And they show that 1,000 men who are offered PSA-based screening tests, and they kind of go through what happens, how many get a positive result, how many will end up with a prostate biopsy, how many will have surgery or radiation treatment. But they summarize it here at the end to show that 1 person out of 1,000 will avoid death from prostate cancer. On the left here, 3 will avoid cancer spreading to other organs, which most of us would call a pretty good benefit. But 5 will die for prostate cancer even after surgery or treatment. So this number is a big number here. The other thing that often draws attention of our patients is that surgery or radiation treatment can cause erectile dysfunction in 50 of those men and urinary incontinence in 15 of those men. So those side effects of treatment are relatively big numbers. The USPSTF is currently reviewing the prostate cancer screening recommendation, and hopefully they'll have another draft recommendation in the next year. I'm hoping that they redo this chart because now that we're doing more MRI-driven prostate biopsies, some of these numbers might be different. The number who go to surgery or radiation treatment might be different. But this is our current infographic that we're sharing with patients. The next question that comes up often is what do we do with patients who seem like they're at high risk for prostate cancer? So again, from the 2018 USPSTF recommendation, they looked specifically at African American men and said that there was insufficient data. They really said that this was a call for an area where more research is needed. For men with family history, they also said there was insufficient data about the benefit for prostate cancer screening for these men. The American Urologic Association, like I said, in 2023, they said those with Black ancestry, we should consider starting at age 40 to 45. So that's 5 years younger than those who are not of Black ancestry. For strong family history, they said very similar, consider starting at 40 to 45. By strong family history, they said a first-degree family member who has invasive prostate cancer. So prostate cancer that either spread to other organs, spread locally, and cause some sort of morbidity. So this is a difference between the two groups. The AUA, since it's more recent, did include some additional data in their recommendations, which showed that those of Black ancestry have a disproportionate cancer burden and a 2 times higher risk of death. They also have an earlier age of onset and an increased risk of metastases before clinical diagnosis. And they did say that if you were going to screen, that they recommend a shorter rescreening interval. So the 2 to 4 years should probably be reduced to 1 to 2 years for this population. About the PSA test itself, I used to tell patients like, oh, don't worry, in 5 years we'll have a better test than the PSA. But this test is still stuck around and is still the test that we are recommending most often. Um, I want to highlight these bubbles in pink here, which show all the ways the PSA test can be falsely elevated. So one, if a patient has a urinary tract infection. Second, prostate stimulation. So that can be from intercourse in the last 24 hours or from a very vigorous rectal exam. Vigorous exercise is another one, particularly bicycle riding, which is why there's a picture there. And then certain medications, so like testosterone therapy, we think can increase the PSA blood test results. There are age-related changes to PSA, which I know we're all well aware of, which is why benign prostate hypertrophy is very difficult to differentiate between prostate cancer development. We know that 5-alpha reductase inhibitors lower the PSA by about 1/2. So if you have a patient who's taking that to help treat lower urinary tract symptoms, you want to probably double their PSA, or you want to, if you're following this PSA test over time, you want to take that to account when you're interpreting the results. As general guidance for primary care doctors, we consider urology referral if the PSA is greater than 4. Most of the times we'll recheck it one time before we put the referral in. And we'll use 2.0 as our threshold if patients are on an alpha reductase inhibitor as above. All right, so these are the major take-home points about prostate cancer. So shared decision-making is key, and I would really prioritize high-risk patients. I'm also looking forward to newer guidelines and updated infographics because I think we had made some changes to how we are treating and diagnosing patients in the last few years. And I think we've done more studies on patients of Black ancestry to help make some more concrete guidelines there. All right, we're going to move forward and now talk about cervical cancer. So screening for cervical cancer is a little bit more straightforward. We have 4 different age groups here that we divide up for cervical cancer screening. For those patients who are younger than 21, no screening is necessary. The risk of cervical cancer in the next 10 years is minute for that group. For those who are 21 to 29, we're recommending cytology alone every 3 years for that group of patients. For those who are 30 to 65, you have a choice of 3 different strategies. One is you could do cytology alone every 3 years. You can do cytology with high-risk HPV testing every 5 years, or you can do high-risk HPV testing by itself every 5 years, as long as you're doing an FDA-approved test for that screening modality. And then the last choice, last age group is if you're older than age 65, we recommend discontinuing screening. And I put an asterisk there because I have a whole slide to talk about who is safe to discontinue screening when you're older than 65. All of our societies kind of highlight that we should avoid doing pap smears for women who have had a hysterectomy with their cervix being removed if the reason for the hysterectomy was benign disease. So women with fibroids or other reasons like that who had a hysterectomy, we probably should not be doing pap smears for them. And then they also advise against doing HPV screening for women between 21 and 29. That group has high rates of HPV positivity, and sending them on for colposcopy and other things has more risks than benefits in that age group. One of the other things that comes up a lot is patients who have already had HPV vaccines as younger women, and they say, do I need to be screened the same? And that right now the screening is the same intervals regardless of HPV vaccine status. So the question like I raised is when to discontinue screening. So everything I'm going to say below really is for females who are immunocompetent, so no immunocompromise. Um, in order to discontinue screening, you need to have had no history of CIN grade 2 for the past 25 years, and you have had to have had adequate prior screening. And there are a few different definitions of prior screening that is adequate. And that's 2 consecutive negative primary HPV tests within the past 10 years. And the most recent test has to be within the last 5 years. Or you could have 2 negative co-tests, so a PAP with an HPV test, and the most recent test should be in 5 years. Or 3 consecutive negative regular PAP tests with the most recent within 3 years. So I think that this is the part that is challenging, I think, is that if you don't see the report, you don't know exactly when the last test was done, then I don't call that adequate or sufficient. And if I can't get those records, then I think it's better to err to continue screening until you can meet these criteria. Yeah, so I said if the results of screening within the past 10 years are not known, then prior screening is not considered adequate. And then the other patients who I think it's okay to discontinue screening is those with limited life expectancy. So if it's less than 10 years, there's not a strong benefit from cervical cancer screening, so we should discontinue. The high-risk HPV testing is kind of a hot topic, I think, in cervical cancer screening. So the USPSTF made a revision in 2018 where they added high-risk HPV testing alone as a possible method. And in 2024, they've issued a draft recommendation. It hasn't been finalized, where they're going to add self-collect high-risk HPV testing as a preferred strategy. So that's a strategy where patients can collect their own samples and submit those as their primary screening result. Now, only certain HPV tests are approved by the FDA for primary testing or for self-collection. And so even though that recommendation came out in 2018, as far as I know, none of the Emory sites or at Grady are not available to do that testing by itself. If you did do high-risk HPV testing either on a standalone test or as co-testing, if that result is positive, which is abnormal, then there's reflex genotyping for HPV type 16 or 18, which right now are our highest risk types. Once you obtain the PAP results and their HPV results, there are apps available or a web platform where you can type in the results and go through an algorithm to find out what you should do next. So whether or not you should refer the patient for a colposcopy or more testing, and whether or not, and when that patient's next PAP smear should be. So those are yeah, there are algorithms, but they're not easy to memorize, so it's easier to use the app or web-based platform. This is a comparison that I accessed from UpToDate about cervical cancer recommendations by 3 different major societies. So the USPSTF is on the top, the American Cancer Society is in the middle, and the American College of Gynecology is at the bottom. The most important part to know is that they really coincide in their screening in pretty much every parameter. The only place they differ is the age to start screening. The USPSTF and the American College of Gynecology both start at 21, and the American Cancer Society starts at 25. They all agree that 65 is the year where you could consider discontinuing. They all agree that if a patient has had a hysterectomy for benign disease, that we don't need to do pap smears for them, and that they all agree that patients with HPV vaccines should be screened the same way as those who are unvaccinated. So most of these guidelines are the same between the major specialty societies. The last slide that or last two groups I'll talk about are HIV positive women, or if you have a woman who's immunosuppressed. This is an area where we often miss screening patients appropriately. So for these specific patients, if they were diagnosed with with HIV or started on immunosuppression before age 21, they should have cytology within 1 year of their start of sexual activity. If they're diagnosed after the age of 21, then you should do cytology at the time that they're diagnosed. Um, for ages 21 to 29, you should do cytology every year for the first 3 years, and then you could space out to every 3 years like you would do in a woman who is not immunosuppressed. And then if you're 30 and older, you should do cytology every 12 months for the first 3 years. And then you can move to cytology and high-risk HPV testing as an every 3-year strategy. This is a group of women where you continue to screen them after age 65. What does it mean to be immunosuppressed? Well, you should start a patient within 1 year of immunosuppression. And we think it applies to those with IBD on chronic therapy, those patients who are on lupus or patients with lupus or RA who are on 2 immunosuppressants. So if they're patients on 1 immunosuppressant, then by the guidelines, they don't meet criteria for the earlier screening. But 2 immunosuppressants, we probably should think about doing the more frequent screening. And this is all related to reduced clearance of HPV, and so thought that that is what puts them at higher risk. And the last category is solid organ transplant. All solid organ transplants on immunosuppression should be treated again with the same interval. All right, last category is screening for women who have sex with women. This comes up a lot by patients and by trainees about what screening parameters we have for them. Cervical cancer screening should be offered according to guidelines, regardless of a patient's sexual orientation or practices. When you interview sexual minority women and ask them why they did not have cervical cancer screening, some of those reasons include lack of health insurance or access to health care, prior negative healthcare experiences, or a belief that pap tests were unnecessary. And so those bottom two reasons are things that as primary care providers that we could really provide more knowledge and provide good healthcare experiences so patients get screened equally. All right, so these are take-home points for cervical cancer screening. Consider a patient's immunosuppression status when you're trying to determine the screening intervals for a patient. And then be mindful when stopping screening at age 65. It's not just 65, your patient's done, but you want to look back at their last screening test, think about their older history. Did they ever have CIN2, like a LEAP or a cryotherapy procedure? And are they immunosuppressed for any reason before you decide to consider stopping at age 65. Okay, all right, we're on our last cancer. This is breast cancer. Screening for breast cancer was updated in April of 2024. This is the second most common cancer and the second most common cause of cancer death among US women. The recommendation here is to screen women every 2 years starting at age 40, and that there's insufficient evidence to screen over age 75. So the change here in April of 2024 is that the screening age dropped from 50 to 40. So it was 1 decade earlier that they're recommending screening. Digital mammogram or digital breast tomosynthesis, which is often referred to as 3D mammogram, are the two strategies that are recommended. This strategy applies for average risk women and for women who have an increased risk of breast cancer, such as having a family history of breast cancer. So screening every 2 years is sufficient for the majority of women with family history of breast cancer. And then you can use your own clinical judgment about whether to screen for breast cancer for women 75 and older. So it's insufficient evidence. It doesn't mean that we should not recommend screening. I have patients with a long life expectancy who continue to have their screening in their late 70s. This is the chart from the 2024 published recommendation about why screening was moved to 40 from 50. And so you can see here in the top, it shows breast cancer cases that are averted with biennial screening starting at age 40 is 8.2 versus 6.7 cancers if you started age 50. So that's 1.5 breast cancer deaths that were averted. And then for Black women as a specific subset, the number of cases averted is also 1.5 cases. You can see that there are higher rates of breast cancer in the 40 to 74 and in the 50 to 74 group for Black women specifically. I will highlight the false positive results here in this column. You can see it's about a 50% increase in false positive results when you move the screening age down to age 40. So that's one of our possible harms here. One of the big topics that comes up when patients are talking to us is dense breast tissue. So what we know about dense breast tissue is that it's associated with reduced sensitivity and specificity for mammography and an increased risk of breast cancer. The Mammography Quality Standards Act went into effect in September of 2024, and this regulation required by the US FDA requires mammogram screening centers to notify patients what their breast density is. If they have dense breast tissue, they need to inform them that dense breast tissue increases the risk of breast cancer, makes it harder to detect it on a mammogram, and that other imaging tests may help to find cancer. This is the part that's tricky. Most mammogram reports say, please consult with your doctor about additional screening tests. But the USPSTF has found that there's insufficient evidence for any supplementary screening like an ultrasound or an MRI in women with dense breasts. So this is an area that definitely needs more research. Most of us are screening women annually if they have dense breast tissue rather than every other year, although this is not based on a strong amount of evidence. But since these women are at higher risk and we think mammogram has decreased sensitivity and specificity, that's a strategy that many of us are using, although this is an area that more research is needed. Last thing that we'll talk about is high-risk patients for breast cancer. So many patients have family medical history of breast cancer and they're concerned about their risk. So these are the patients that we know are very high risk. So not moderately high risk, but very high risk. That's if you have a genetic marker syndrome like BRCA1 or BRCA2. If you have a history of high-dose radiation therapy to the chest at a young age, so yes, less than age 30. If you've had breast cancer before, or if you have a prior biopsy with a high-risk breast lesion like atypical hyperplasia. Those patients are considered to be more high risk. For any of those patients, you can use certain tools where you'll compute a lifetime risk of breast cancer. If their lifetime risk of breast cancer is more than 20%, then the American Cancer Society suggests supplemental screening with an MRI. And this has been out since 2007, and many of us will alternate and have patients have an MRI. 6 months later, they have their mammogram, and then 6 months later, MRI, and follow that pattern for screening. All right, so this is our summary for breast cancer. Our take homes are that we should offer a screening starting at age 40 and that there's more research needed specifically about dense breast tissue. I think the percentage of women who have dense breast tissue is over 30%. It's a very high number. All right, before we conclude, I'll say before you screen for any of these cancers that we talked about, think about life expectancy, think about the risks of testing for your specific patient, the risks of overdiagnosis, and the risk of overtreatment. They exist for each of these, and some of them were on the slides that I presented, but I didn't go into them in huge detail. The other thing I'll have you think about is the areas that there is no routine screening. So periodically, the USPSTF updates their information about bladder cancer, oral cancer. They said there's really insufficient evidence to provide to screen for this. So patients say, should I leave a UA to check me for bladder cancer? And we don't really have a lot of evidence to support that. And then they have evidence to recommend against screening for some specific cancer. So these are all D recommendations. Do not screen for them. And that's ovarian cancer, testicular cancer, thyroid cancer, and pancreatic cancer. If you're interested, they give nice clinical summaries on the website about why these cancers, why either they don't have a good screening test or the screening test is not beneficial because it doesn't help us diagnose the cancer at an earlier stage. So it's interesting to read those guidelines if you're curious as to why we are not screening for those cancers. So in conclusion, I'll say routinely offer screening for breast, lung, colorectal, and cervical cancer according to the recommendations we discussed. And that shared decision making is especially helpful for discussion about lung cancer and prostate cancer. All right, I'll close. This was taken, yeah, 11 days ago, so we'll see what today brings for us.
Thank you, Dr. Vohra-Khullar, for this really high yield talk for many of us. And I'm glad we have time left over because we have many questions for you in the chat. Starting with how does genetic testing factor into primary care screening? And this was sort of early on in the talk before you had sort of done a little bit of a deep dive with each of the specific cancers, but perhaps more broadly speaking.
So genetic testing probably has its biggest role really in breast cancer screening. There are several screening tools that are available that are recommended by the USPSTF to enter patients' family history, and then some of their other screening parameters to decide whether or not they are high risk for mutation for a breast cancer gene, and those patients should be referred for genetic screening. So that's probably the area that we have that most flush out where our job as primary care is to take a careful history and help decide whether or not patients should have that conversation with the geneticist about further cancer screening.
Excellent. And Dan Dressler asked, do you have any comments or thoughts on the recent study suggesting that colon cancer colonoscopy screening should be extended to 15-year intervals if no family history and negative initial screening?
For negative initial screening. Yeah, no, Dan, I haven't seen that study more recently, so I don't have a lot of thought process about that. There are, when thinking about the different intervals, there is a thought that there are some population of patients who are more prone to making adenomas, and there are patients who will not make them at all. And so that idea, I think, is probably looking more specifically at that scientific understanding is that we have patients who make a lot of polyps and those who make none. And maybe for those who make none, we could further space it out, but I haven't seen that actual article yet.
I believe this is during your section on prostate cancer. The data on Black ancestry has been shown in some literature to be inaccurate. Can you comment on that?
Maybe they can put a little bit more about what they mean by it's inaccurate.
Let me see.
Like comment a little bit more.
I don't know if David Alter is still here. He may not be. All right. We will move on then. There were comments about self-collection for HPV screening at Grady and the transgender care clinic as a possibility.
I know they do a lot of self-collection at Grady to try and help. I know in the prep clinic they are doing that. I don't know if they're doing it for HPV. I would love for someone to comment on that. It's a great strategy. And like I said, this is still a draft recommendation for cervical cancer screening, but it should hopefully be finalized in the next few months. And then it would be great if we had that. It would hopefully open it up to many patients who don't like undergoing a pelvic exam.
Pam, Marshall Florent was talking about that for the Grady primary care clinics, and we're waiting to see if they count cervical cancer screening with that self-collection. I think we're a little bit ahead of the guidelines still, but I think it's a really important point, and I know that a lot of people haven't heard about that. Falls into the best screening test is the one that the patient can actually get done.
Can actually get done. Yeah, thank you.
Perfect timing. Next question actually comes from Ted Johnson. The USPSTF recommendations seem to often differ from specialty society guidelines. Why do you feel this is so? And are there any ways that this helps providers or patients?
I think it's a really good question, Ted. Chris Massey had connected me with one of the doctors who is on the USPSTF. And so I talked with him a little bit about how they make the guidelines and some of the questions that I had about specialty societies and how they differ. And at least in his opinion, it's really about the mandate that they can only make recommendations based on evidence, not on expert opinion. He also, I think, really highlighted the USPSTF is really kind of a starting point, but it shouldn't be a limitation. And so I have patients who really want to have a mammogram every year, and most insurance companies will still cover to have that screening test done every year. And so it's really a starting off point rather than a place where we need to block patients from having screening tests if they have a strong desire to be screened more frequently. But I think it's probably, my understanding is that it's about expert opinion versus solely on what the evidence shows for benefit. I was looking to see whether or not the USPSTF looks at studies from other countries, and a lot of their primary data sources are based on large population studies that are done in other countries. So it's, not just based on that.
Thanks.
In the cancer screening, but I don't think we covered this today. Any different screening for patients with pancreatic multicystic disease in different forms?
Hmm. Yeah, that's not something I know very much about. So it's not related to any of the specific cancers that I talked about for screening. And I haven't read the pancreatic screening article in a little while.
Hey, Pam, this is Ted Johnson again. I've talked to Michael Gambello in Human Gen. First of all, you did a great job at this. I've tried to summarize this. You did a fabulous job. I did talk to Michael Gambello in Human Genetics, and there's kind of a crossover between genetic screening and cancer prevention and genetic screening for other things. And I'll just put kind of what Michael cites into the chat. It's basically what CDC calls tier 1 conditions. And so you did get the family breast, hereditary breast and ovarian cancer. And for some people, that's why you get into an ovarian cancer pathway, and then some other non-cancer ones. And so, and it leads you into some interesting places because men with BRCA2 in particular are probably at a higher risk group for earlier prostate cancer disease. And so, but it's very interesting, and it's not fully overlapping. Thanks.
Yeah, thanks.
And otherwise, just a lot of comments on the excellent presentation. So any other questions before we wrap up? And thanks, Ted, for adding that to the chat. All right. Well, thanks everyone for being here. Please do go ahead and scan that QR code so that you can access the survey where we can get some feedback. And at the end of that survey, you will get the CME code for this week's session. And thank you again to Dr. Vohra-Khullar for being here and sharing this excellent talk. All right. Bye, everyone.